Bismillahirrahmanirrahim. Thank you very much for a very lavish introduction, and I'm thankful to the organizer, and Assalamu alaikum everybody. So my talk is a simple talk, but time is issue and time is tissue in this subtopic. Next, please. So my talk is having a roadmap of updated review of diabetic foot, and then time is tissue. And introduction is this thing. And because this is the fact, lifetime, and because this is the fact, it is increasing. 20% people, they will have the amputation. And if you see this is the importance when I gave the first slide. It is equivalent to the other cancers. Rather, 50% mortality after amputation is more than 50%. And what is the burden? Simply about 140 per 100,000 minor and about 94 amputations in a major amputation is there per 100,000. And amputation is more if the infection is severe. Amputation is more if the ischemia is severe compared with the people who don't have the ischemia. And this is the burden, rather it is the natural history which is happening with diabetic foot. People with infection, neuropathy, diabetic foot ulcer or diabetic foot. It is Charcot, it is ulcer, it is infection. And it leads to what? Amputation, decreased quality of life. And it is important to note that recurrence is there in about 40 to 50, 65% of the cases. And this is the prevalence in the form of the prevalence, the burden is, which is more in longer duration of diabetes, uncontrolled diabetes, who are having smoking, a history of smoking, and people who are having decreased BMI. And this is the local data, which is showing that we are having the prevalence of 16.3%. And if you see all the studies right from 1909 to 22, we are from 6% to 50%. So this is the total burden because of which we have been discussing this thing over here. And risk is simple. Medical students sitting over here. These may be the local factors like the foot, it may be deformity, it may be edema, it may be previous ulcer, it may be previous amputation. With the like the cardiovascular, retinopathy, kidney disease, smoking, and decreased weight and inactivity. With these factors and keeping in mind the diabetes, which is decreased immunity, with autonomic, motor, as well as sensory. So this is, and this is the pathology. The normal foot and the ulcer, ischemia, infection, angiopathy, along with decreased immunity, deformity because of the motor neuropathy, loss of sensation because of the neuropathy, and dryness because of autonomic neuropathy. And very important factor which is there in our country, raat ko ya din mein, they are having the bilkul heater ke saath jaake. So the thermal injury is a very important part over here. So this is, with this, we all should be thinking that we should be keeping eye on it, isn't it? Aisa hi rakhna chahiye? No. This is the new thing, that whenever the diabetic foot is there, retinopathy should be sought out. Or when retinopathy is there, we should be reciprocally seeing for the diabetic foot ulcer. So this is the. And now, this is the classification. There are many classifications. Wagner se shuru kiye, 74 uski studies aa gayi, but it was not confirmed why we have that classification. So now we are having 2 or 3 commonly used classification in diabetic foot ulcer management. One is this Sinbad. It is site, ischemia, neuropathy, bacterial infection, area, and the depth. It is basically for the communication with the health professional. Second is the University of Texas. It is more the severity of the infection. It is having grading and staging both. Grade 3 mean osteomyelitis. Grade stage mean 4 mean when both ischemia and neuropathy is there. So more the staging or grading, more is the amputation. But as far as the prognosis is concerned, Wi-Fi classification should be opted, but it is not available everywhere. You cannot have this classification, and still people are thinking, should we use it for this prognosis or not? There are many more PEDIS and IDSA classifications are there, but we will be discussing 3 at a time. So the last one is the ischemia. It is either it is the ABI or it is the toe pressure. Depending upon it, the severity is there, the amputation is more over there. So this is simply the management plan. So this is the management plan. It is scoring the ulcer, knowing about the prognosis, local wound, which is not given importance. Then is the offloading, optimizing perfusion, and it is optimize the metabolic management. So this is the overview when we are managing people with diabetes, with diabetic foot. Offloading, if it is the non-plantar, simply the ankle high, or if it may be the footwear modification or the toe spacer. If it is the plantar one, you may be using the knee high removable or non-removable. But the problem is when we are having forefoot or midfoot plantar ulcers. So you may be using non-removable, removable, ankle high or knee high, or even if it don't have, you may be having the modification local of the shoes, you may be making the sandals as well. Kuch bhi nahi hota, so please put the patient at rest. Chale hi na, paun na rakhe niche. Then is the debridement, oftenly neglected. It is the sharp debridement will be cutting off the debris necrotic tissue, which is the hub for the anaerobe, multiple anaerobes. When you're cutting it down, you will be more having healing. This is very evident with this picture and study. And this is when you are treating infection. If it is mild one, you know what is the characteristic, and if it is the severe one. This is the morphology. You may be just seeing it and then going for the management. And if it is severe one, go always with the parenteral. If it is mild one, oral. If it is moderate one, start with parenteral and go with the oral. And now this is time is tissue, but time is issue over here as well. So this is the fast track pathway in multidisciplinary team is the fact which is saying that their time is tissue. People have seen that why the mortality, why the amputation is more, because of many reasons. One is that patient is not recognized. It is very important to go to the doctor. 56 to 60% of the people in Europe don't know when the ulcer started. And even if it is started, it is gone to the GP or the family physician. It takes about days, no, weeks, months when they're reaching the proper place. So keeping in view the constraint in our country, constraint in all the poor countries, resource constrained countries, we should be opting it, taking or borrowing it from the D International or the other guidelines. You see on the right side. You see on the right side that whenever we are not properly managing it, ulcer size is increasing, and ultimately it leads to amputation, either minor or major. So this is a summary which I have discussed up till now. So what to do? So is it effective? Yes. The evidence says that if you are having a fast track approach program, then you can have a decrease healing time, decrease hospitalization, and decrease amputation. So this is evidence-based, and this is the study. In 2008, Bakai people said that 27.8% people were having amputation. But when they started the multidisciplinary team and fast track, as they claim, the amputation has gone to 3.99%. Toe, minor and major both. So this is the importance of the fast track pathway. But whenever people come to us with the diabetic foot ulcer, we should be having a holistic approach, taking a detailed history, meticulous examination, investigation right from blood sugar to the angiography or the ABI, and then you will catering the patient in that form. And in this way, we are going to categorize people in 3 categories: non-complicated, complicated, and very complicated. Very complicated, within 24 hours, the GP should be sending the people to the specialized area. And if it's uncomplicated, he can be keeping it with the help of the fast-track people and the podiatry people and the people who are having expertise in diabetes, diabetic foot ulcer management. Keeping over there 4 weeks. Some people say 2 weeks. And then if reduction is less than 30% of the size, please send it to the specialist people. So with this, I think probably I'm in time. So the key message is that if we want to decrease the burden of this disease, we should be educating not only the doctors, family physicians, the GPs, the consultants, but at the same time, we should be educating the patient as well. And we should have the authorities for developing the guidelines, developing the teams in each institution to decrease the burden. Thank you very much.